Good afternoon. We have Chris Harris, safety of the NFL, okay? And he comes in twice a week, and he had his massage, and he had his muscle activation, and he's having his stretching and everything, okay? He spends about an hour and a half, 2 hours here every time he comes in. This is the kind of therapy and treatment we do. We also can do different type of limited care, but if you want the full scope, this is professional athletes. We want to keep them healthy. We want to enhance their career, and we don't want them to have terrible conditions after they retire, whether it be new hips, new knees, new spines, brain dysfunctions. So we do all we can. Why you say brain dysfunction, Dr. Vitanzi? What can you do to help their brain with all these concussions? Well, gee, let's see. What controls the brain? Actually, there's a nerve supply at the base of the brain stem, okay, controlled by the first cervical vertebra. If you look at any chart, scientifically, you will see the first cervical vertebra. It's called C1. C1. Blood supply to the head, pituitary gland, scalp, bones of the face, brain, inner and middle ear, sympathetic nervous system, and eyes. Well, that's good enough for me. This is a scientific document developed by research that says the first cervical vertebra helps control the blood supply to the brain. Okay, now, many years ago, there was a wide receiver for the Denver Broncos. His name was Rod Smith. Every time he'd hit the ground, he'd go unconscious. Nobody knew what was going on. I said, Rod, let's adjust your first cervical. C1 on the left. 3 times he was adjusted. He was having brain type of symptoms where the concussion from hitting the ground shocked the upper cervical spine and caused him to temporarily lose consciousness. Not only was the circulation cut off to the brain, causing concussive symptoms, the vertebra was rotated, pinching into the brain stem, causing more concussive symptoms. He had all the tests, medications, nothing helped. He had 3 adjustments, never reoccurred again, ever. As a matter of fact, there are other people that are very close to us have had the same concussion type of symptoms, and they also got well. And I can't say any more, but it works very consistently, very regularly. So let's get Chris. Go down to his feet. Okay, not bad, Chris. Tight Achilles tendon on the right. High calcaneus. We get his feet, flex the feet. We got very flat feet here. Some of the greatest athletes I've taken care of in almost 43 years, and I've taken care of great athletes, have always had flat. The fastest, best ones have flat feet, man. For a while, there are certain doctors that try to develop orthotics to correct the flat foot. Why would you change something God gave you that's normal for you? And what they did is they caused stress fractures in the tibia. So I don't try to correct flat feet with orthotics. I adjust them, keep them in their normal range, and let them fly and be fast like Chris Harris is. Very fast. So, we'll just tap at the navicular. I know what some people are saying. Oh, what do you mean about flat feet? Some you correct, some you don't. You know, you have to make a judgment call here. Okay, if there's a big problem, then you do more to correct it. If it's not a problem and it's part of his physical makeup, don't be so anxious to change things, completely. Like, why would you have an orthotic made for a bad foot? Unless you had a broken foot, a disability, diabetic foot, or some significant problem with the foot where you have to have an orthotic because you had it mashed or damaged or whatever. But in a relatively normal foot that's hurting you, why would you trust an orthotic to move the bones in your feet? Nobody's that good. No computer, nobody. Isn't it more sensible to be an expert of the foot, adjust all the bones in the feet, make your foot normal, then put the orthotic in that maintains the adjustment and supports it and gives a cushion to the ground? That's what's worked for me. I was certified to do orthotics in '74. I quit doing them because they weren't working. Then I learned from Dr. Heron to adjust the feet. Now I got 99% success rate using ortho feet after I adjust feet. I'll show you an ortho feet if you want. Very good. All right, so let's scan. Little dorsiflexion, Achilles tendon, a lot softer, eh, Chris?
Yep.
Okay, heels, nice wobble, a little tight on this right heel. This right heel is not wobbling like the left heel. Remember, the heel hits and it's got to wobble, it's got to move. It can't be hit and fixated, or if it's supinated, you're going to hit and it's going to roll in and sprain an ankle. We try to prevent that stuff from happening. Let's go up the pelvis. Okay, put your right hand here. Okay, left hand here. Okay, look at his elbows. That's nearly perfect, isn't it? Now, this is very excellent. Okay, drop down. But this young man gets treatment regularly and keeps himself. He don't care if he hurts or doesn't hurt. He has a routine. Why? Because he's a professional. He's the ultimate professional. He's going to stay well. Don't get hurt and try to get well. Stay well. Plus, I have him sign a contract, like if they play so long, I get a piece, you know, so... No, just kidding. Just kidding, agents. All right, let's get the issue. Excellent. Movement palpation, just palpating the vertebrae that are fixated, at the same time feeling the heights of the ribs to see if there's a spinal curvature. If there's a lateral curve, there's always a convexity on the side of the... so in other words, if I'm leaning to the right, and my curve is convex on the, if I'm leaning to the left and my curve is convex on the right, I'm rotating posterior. Always, 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 unless you got a lot of rods and hardware. A normal body reacts a certain way on gravity. If it's a normal body, you got 2 legs, you're human, you stand, gravity has an absolute same reaction on everybody, barring the complications you may have to eliminate to get back to the normal compensatory state. And there are different complications. So eliminate the complications, then look at the normal compensatory change of the spine, then fix the compensation. You have to fix the complications before you fix the compensations, or it won't work right. That'll give you something to think about, huh? Okay, a little tight right here, Chris. And man, that first cervical is much better. Remember how that used to? Yeah. It's kind of tight and fixated right here. So on your back for me. So we got C5, C6, little tight, not moving well, but that's that that lordotic curve in the spine, and he doesn't have any rotation of C1, but it's not moving as well as it should. Remember, these are professional football players, man. They got a tough job. Bend your knee for me. Okay, roll out, beautiful. In, beautiful. That was your kneecap. You're okay. Bend this. All right. Let's go in. Good. Let's go out. Happy. Dorsiflexion. Feet, knees, ankles, anything bothering you? You're doing pretty good.
Doing pretty good.
Doing pretty good. I get a drop in the talus here. As I dorsiflex, I feel that this talus bone here drop down. So when I do dorsiflexion, this just drops out right there. It's different than that foot. The right foot is different than the left foot. I'm not sure. I'm just going to try to put it back in place. It doesn't hurt or anything. It just seems to me it shouldn't be that way. So come over here. You can do it this way. You can grab it this way. Okay.
When I did have like ankle sprains, this one always on my right.
You tell me this now?
Pass.
What is it?
I said in the past, rolled my ankle on this right.
You've had chronic ankle sprains.
Yeah.
So he's had chronic ankle sprains. This is just probably a remnant. So I just think I'll correct it a little bit. I'll try to get it this way. Come on. Clunk. Clicked right in, didn't it? Clicked right in. The thing is, if it's somewhat normal ankle, 80% normal or better, when you do that talus and you have it at the right angles, clicks right in. If you have to pound it and pound it and pound it, you stop. So now, it doesn't cave in. So now, it doesn't cave in. It doesn't completely drop out. Is that noticeable difference, Doc? You see that? Okay, bring this one up. And this one, see, it's more like, now they're more symmetrical. Okay, this one I felt was normal, so I'm not going to adjust it to be abnormal. This one felt abnormal, so I'm adjusting it to be normal. Best I can say. I did that. Okay, let's do that mid-back. Lift up for me. Thank you. Occiput. Even. First cervical. Tight midline. So I'll do a little loosening this way and nothing specific to correction, mobilization. He is doing really, really well. I'm going to adjust him per his subjective complaints and per objectively what I find. There's no sense in going overboard. Okay, period. Come on up. Swing your foot over this way, son. I got a cross too, man. Look, we both got crosses, see?
Good to have it.
Yeah. This is our leader here on the cross, right? Okay, tips of the scapula, even. Second ribs, symmetrical. Sternoclavicular joint, symmetrical. Hands behind your neck, lock your fingers, loosen you up a little. You're good till next week or Friday, Saturday.
Friday.
Saturday, right? Saturday. Thank you, young man. God bless.